what kind of services are to be provided. And it can vary from scheme to scheme, but for PMJ, is it tertiary care? Is it outpatient? And within tertiary care, are we going to be opening it up for everything, including elective surgeries or cosmetic surgeries?
Just paraphrase what you're saying, Dr. Bhushan. Essentially, you're saying identify the target segment,
Yes.
which is the people who are going to benefit. Then you have finalize your product, which is what all packages you're offering in this.
So I was that traveling salesperson. I was going around each state, talking to the chief ministers, chief secretaries, and asking them to join the scheme and sign the MOU with us so that we can implement. Like I was saying, communication was focused on many target groups, but main one were the beneficiaries, and we were following a multi-pronged strategy 50433. And on that day, we got about 26 lakh calls on that number.
This episode of Sushasan on Campus comes to you from ISB Hyderabad. And I'm speaking to the very well-respected Dr. Indu Bhushan. Dr. Bhushan is a 1983 batch IAS officer of the Rajasthan cadre. He took a very early voluntary retirement from the IAS, travelled across the world and worked in different multilateral institutions before he was handpicked by Prime Minister Modi to run his most ambitious scheme or program, Ayushman Bharat. Nobody gave Ayushman Bharat a chance when it was first conceptualized, but today it seemed to be a success. So in this episode of Sushasan on Campus, Dr. Indu Bhushan talks about his own life journey and also very interesting nuances of Ayushman Bharat. Do watch out. So pleasure to host you on Sushasan.
Thank you for inviting me.
Dr. Bhushan, you've had a very unconventional career trajectory, right? You were a 1983 batch IAS officer of the Rajasthan cadre. You were in the services for around 9 odd years. That's the time when IAS officers become collector, DMs. That you had already a couple of stints of that by then. You took voluntary retirement at that point in time, very early, a lot would argue. And then you had an international career, first at the World Bank, and then a long and distinguished career at the Asian Development Bank. You also studied health economics and did your PhD from the best in the world, that's the Johns Hopkins University. And then in 2018, you were almost handpicked by the current government to lead what's called Ayushman Bharat. And Ayushman Bharat has many pillars, but the first pillar it started off with was the PM Jan Arogya Yojana, or PMJ as it's called, which was a big step forward towards universal health coverage. And you were picked up to be the first CEO of NHA, the National Health Authority, and you conceptualized, designed and implemented PMJY. So I'll talk a lot about the scheme, but before that, quickly, just as to understand, what in your view got the government to pick you up? Because you had this intellectual career, you were out of the services. So why did they pick you up, and what was the process? Who reached out to you? What was the conversation? Can you share a little bit on that, and then we'll get into the content.
So first of all, thank you, Gaurav, for having me here. And so I'll share with you what happened, but there's, as you can understand, things that I can't share in public. So, and many things happen because of luck. It's where you are and what time you are. So you have to be in a place at the right time and right place, right? So the day government has announced the scheme in the budget, I was visiting Delhi for something, and the same day evening I was meeting with some very senior official for dinner. And during the dinner I was discussing about this scheme, and I was saying that such a path-breaking scheme, game-changing scheme, probably it should have come 20 years ago. And I was sharing my experience of implementing a similar scheme in Vietnam, Cambodia, before that Mongolia, China, Thailand, and how those schemes are different as compared to what is being proposed here and compared to each other. So that person said, you will be the right person to lead this scheme. Would you like to come? I said, it will be a dream come true because, who gets the chance of implementing the biggest scheme in the world, which will help 500 million people, 50 crores. So that's a dream. So actually, and second thing is that everything happens with luck, but also some good things happen over drink. So it was over drink. So we were discussing that. So next day morning, he calls me, I'm going to be meeting the Prime Minister tomorrow. We discussed about it yesterday, and I want to talk to you now in the morning whether you are serious that you want to come and join if given the chance. I said, of course I am serious. These things no one says in jest. And I forgot about it. And later sometime, I was in Manila. I was actually Director General of East Asia Department, very cushy job, very well paid. And I was on the treadmill on Sunday. And on Sunday, usually work-life balance, I don't take official calls. And there was a phone call coming. And so I was just, and it was unknown number. Then I realized that this number was a number from Delhi. So I thought maybe someone from home is calling, although my parents don't live in Delhi, but maybe there's some problem. So I picked up the phone, and so it was from PMO, and they wanted me to come the next day to meet with the principal secretary of the PM for this job. And I said, I'm going to actually China today, and I'll be in China, and I can come only the following week. They said, following week will be very late. We want to process it fast. And not process, we want to have a chat. We have many candidates. Can you come earlier? I said, the earliest I can come is next weekend. So he said, weekend is fine because we work on Saturdays, like you guys work on Sundays. And it was a new thing for me that people work on Sundays and Saturdays. So I said, fine, I'll come on Saturday. So on the way back from China, on my own, I came and I went to PMO and I met with the principal secretary. It was a 15-minute meeting, and I came out and then I asked the joint secretary who had called me earlier, so what are the next steps? He said, we don't know, principal secretary will decide. So I was very cheesed off, I come all the way and they just don't tell me anything, what the next steps are, why I'm here. I said, maybe the government is like this. I went back, but 3 days later, there was a buzz in ADB building, Indian ED, in the person, India's representative in the board. He was looking for me that Mr. Mishra wants to talk to you. And so I spoke to him. He says, Indu, we have a problem. We don't have an application from you for the job. So without your application, we can't proceed ahead. I said, are you giving me the job? But I need to know the terms of reference. And I said, send me the TOR and we'll take care of it. Send me the application and we'll send you all the information. So I said, what should I write? So he said, he dictated me the application and I sent it by email to him right then. So, and after that I left. I went to Vietnam because I was, and on the way back, when I came back to Manila, I saw many missed call on my cell phone, and they said that Appointments Committee of Cabinet has approved your appointment. You need to come and join tomorrow. I said, are you joking? Because I'm in this job, heading a department. I can't really come up and leave. I have a notice period. And of course, when the Prime Minister says something, ADB also listens. So I joined in 4 days' time. So one day I was sitting in Manila in my house among a lap of luxury, and 4 days later I was in Delhi working on a new scheme.
Yeah, many things very typical of the government, right? If things have to happen, they have to happen immediately, right? If they don't happen, they may not happen for a very long time. So very classical kind of government. And when a call comes, want to meet you tomorrow or the same day, but no matter where you are in the world. But great. So you got the job first, and then you kind of applied for it, essentially, right? So And just one more thing before I come to the scheme. When you first met the Prime Minister, either before or after, what was his mandate to you? What did he tell you?
I didn't meet him before I got the job. I met him soon after I joined. And so he had, of course, had known about me, and he knew where I was coming from. And he said that, and it was end of April, actually middle of April. And he told me that we need to launch this scheme on 15th of August. And 6 months' time, just imagine a scheme which will reach 500 billion people, 50 crore people, involving 36 states and UTs, and to be launched in 6 months' time, starting from scratch. Because at that time, there was only one cabinet paper which provided some broad outline of the scheme. And we had just two persons and the two government officials, myself and my deputy CEO, who was actually on loan at that time, Dinesh Arora, and then no other staff, not even a PA. So launching a scheme in 6 months' time, of course, was daunting. And so, of course, and I did have a choice.
Great. So let me quickly briefly share for the audience also what the scheme is. So as you've heard, the Pradhan Mantri Jan Arogya Yojana is what is being talked about here, PMJ, and it covers the bottom 40 to 50% of India's population, which is around 10 to 11 crore families, which is around 55 odd crore people. And the scheme essentially says that if you have a medical emergency for secondary or tertiary care, then you can go to any empaneled Ayushman Bharat hospital. It could be a government facility or a private facility, and you get the treatment done in a cashless manner, and up till rupees 5 lakhs per annum as a family. And essentially, we know that health emergencies are the biggest reasons why families get pushed below the poverty line in India. And therefore, it was a big step that the government took through PMJY or PMJ. So what I want to understand from you, Dr. Indu Bhushan, is what were some of the design principles or the principles that you kept in mind at the very start before actually putting down the scheme on paper? We talk a lot in B schools around design thinking, design principles. What are some of your principles there?
Okay, so for a scheme like this, and I think that framework is there for any scheme that you are asked to implement, you have to see at least 5 things. One, who is the beneficiary exactly, and how are you going to identify the person, and how are you going to tell the person that you are eligible for the scheme, and when you go and how do you access services. So one is demand side on terms of identifying the person, right? Second is what kind of services are to be provided. And it can vary from scheme to scheme, but for PMJ, is it tertiary care? Is it outpatient? And within tertiary care, are we going to be opening it up for everything, including elective surgeries or cosmetic surgeries? So a call has to be taken by what are the services that are going to be covered. Third is that how much are we going to pay for those services, and how you are going to be paying for services, in the sense that you can decide the payment, but the same service being given by, say, Max or a district hospital, are you going to be paying them same, although their cost structures are different? Are you going to be paying them based on fee for service or just lump sum based on the contract? So that has to be taken. So the fourth thing is that who will make the payment? Will it be the government directly making the payment, or are you going to be hiring insurance companies to be making the payment? If insurance companies, then how are you going to be selecting insurance companies? And all that process has to be done. And finally, the system, who is going to be implementing it, who is going to be monitoring it, who is going to be putting together grievance redressal system, who is going to be looking at the fraud and abuse system. So all this, so these 5 elements are there in any scheme, irrespective of what kind of sector you are in. demand.
And if I was just paraphrase what you're saying, Dr. Bhushan, essentially you're saying identify the target segment,
Yes.
which is the people who are going to benefit. Then you finalize your product,
Yeah.
which is what all packages you're offering in this scheme. You finalize your pricing,
Yeah.
and it's going to be differential pricing, or it's going to be the uniform pricing for everyone. And then you're talking about the mode, which was the option, I think, in the beginning given to the state
Yeah.
to say that they can either directly pay the amount of the treatment, or they can onboard an insurance company to whom you pay a premium, and the insurance company will then do that. I think most states, opted for the first one, if I'm not mistaken.
There was a lot of politics on that. But one thing I forgot in these 5 things is that who was going to be providing services? Is it the government service, government hospitals only? Of course, government hospitals are already providing services. But private hospitals, then what kind of private hospitals? Whether we are going to be including traditional healthcare dealers, and how are we going to be impaneling private hospitals? What will be the criteria, and what are the kind of contract we are going to be having with the hospitals? So that is the 6th element also, which was done. So based on this, I had 4 verticals on the first week in time. I said, okay, I need 4 verticals. One is the demand vertical, and I need a very strong communication team. It's a new scheme, so you need to have a logo for our scheme. We need to have logo for our organization. We need to have a communication campaign towards beneficiary, but also communication campaign towards hospitals, so that we can attract them and try to. So that was put in place. We hired an agency. Second was a very strong vertical on IT, because if you have to reach 500 million people, you have to implement the project, you have to monitor it, you have to ensure fraud and abuse is not done. It can't happen without a very strong IT platform. So we created IT platform end to end, so that it can provide services paperless and cashless manner. So that was the second strong IT vertical IT. Third is technical people, who will be looking at what kind of services are to be provided, at what rate, fixing the price, and what kind of hospitals are to be impaneled, what are the criteria, and developing all that. Fourth were systems people, in terms of what kind of structure we are going to be having at national level, state level, district level, what kind of people are going to be there, what kind of training is to be provided to them, and how that is going to be done. So apart from these 4 verticals that I had, there was a job of salesperson, because as you know, health is a state subject in our constitution. So we can't enforce a scheme on a state. State has to come on board. So I was that traveling salesperson. I was going around each state, talking to the chief ministers, chief secretaries, and asking them to join the scheme and sign the MOU with us, so that we can implement. So in first go, we were successful. We got about 25 out of 36 states and UTs on board before it was launched. And soon thereafter, we got remaining except 3. Delhi always said that they will come on board. They put that in their budget scheme, but never signed. Orissa kept going back and forth. They never joined. West Bengal, they were first one to join from non-NDA state. But during the general elections 2019, they withdrew. So there are 3 states which are not implementing this scheme. Remaining are.
Got it. So many questions coming to my mind based on what we have shared, Dr. Indu Bhushan, and you also talked about the 4 teams that you had and you being the traveling salesperson here. But let me pick some aspects, right? One thing that was different in PMJ vis-a-vis what was happening in the country for the first 70 years was it focused a lot on the demand side. Instead of saying, let's build hospitals and let's build facilities and somehow it'll reach to the poor, it said, okay, let us give the focus on the poor, get them to kind of demand it, and that's how we'll kind of, that is a fundamental shift. And you talked about the communications team. One of the very unique things that happened at the time, I remember, is the Prime Minister actually writing to all the 10 crore beneficiaries of the scheme, right? So I don't know where you got the data from, but he actually letters went to each of the 10 crore families. So tell me a little bit about the communication side of things.
So, see, like I was saying, communication was focused on many target groups, but main one were the beneficiaries, and we were following a multi-pronged strategy. And one of the key one was that Prime Minister himself was very keen that he would write a letter to each family, telling them that congratulations, you're part of this scheme, and if you're sick, you can follow this process and go to this place. This is a number you can call, with a not only telling them that they're eligible, but also how to use the services. Drafting the letter was easy. Challenge was that he wanted to send those letters in different languages, not Hindi or English, but language of that state. So, for example, West Bengal, he sent it in Bangla. In Orissa, he just sent it in Oriya, although they were not implementing it. So, the letters went in the local language. So, translating that letter into those local languages and ensuring that the translation is real. Bhavarth hai, wo shabdarth nahi hai. So, we can actually translate word by word, but maybe the meaning gets changed. So, we have to confirm from different languages that it conveys the same feelings, same emotions, same message that he wanted to convey. Then imagine printing those letters and putting the address. An address came from the census surveys, and for many of them we had to do cleaning up, and then mailing them and monitoring them that letters have been received in those places. So all that, we had a separate cell working on that, and so that itself was a very extremely complex undertaking.
Another thing that you did which actually worked very well was the call center. So somewhere where anyone could call and get the information about hospitals, where do they do it, and that was also a multilingual call center. Yeah. I know it was used later extensively during COVID also, but you set it up under PMJ. So thoda, if you can share about that.
So Gaurav, that's something I should share, that you don't get everything right in the first place, first time. So when PM was launching this scheme, first he launched on 15th August from the Red Fort, and then that was a pilot, and 1 month later on 23rd of September, he launched it nationwide from Ranchi. So, of course, his office had asked us to prepare his speech, but he has his own speech. We give you inputs, but he will speak on his own. But he refers to it, and then he was going there. He said, "Indu ji, आपने देख लिया क्या कोई ऐसा मैसेज है देना है?" हमने कहा कि सर आप ऐसा करिएगा कि हमारा कॉल सेंटर नंबर है 50433, उसको जरा आप बोल दीजिएगा जिससे कि लोगों को पता रहे कि यहाँ पे कॉल करना है. So like in one style, he said it 3 times in 3 different places कि अगर कोई आपको 4050433 50433, and on that day we got about 26 lakh calls on that number, and our call center got jammed because we didn't have that capacity. And so we learned that there has to be queuing system, there has to be capacity, there has to be overflow there. So all that we learned, and of course for 3 days we didn't sleep because we had to fix it, because we didn't want a complaint to go back to him that you gave us a number but this number is not working. But now this became so robust that it could handle that kind of load. And when COVID came, and in COVID we realized that they gave the number and the same thing was happening. They were even worse. They had given 2 landlines, and of course through landlines, even for Delhi it was not very effective. So we offered that we can easily expand our call center to cover COVID, and it's a multilingual. It has a capacity to put people on wait and tell them how long it will take for them to be serviced. And so we did that. We expanded that, and the call center actually was useful not only for seeking information about PMJ, but also for sharing any grievances telling them any feedback about what is happening. If there's a fraud happening, you can call them. But also, we had used those call centers to call the beneficiaries proactively twice. Once after they were discharged, to understand what kind of services were provided, whether they're happy with the service, and then 15 days later about the health outcome. Because when you are discharged, you don't know how you're feeling. Like the things become more clear after 15 days, and then after 2
Not
weeks.
just inbound, but also feedback.
Yeah,
About
yeah.
feedback. Another thing that is unique about PMJY is that it took a conscious call to say that one, you'll include private hospitals, so government and private both, and you can go anywhere and avail the service. Not necessarily in your district or your kind of local area where you find a hospital and go there, you can go anywhere. And one of the things that comes along with this design choice is an important one is also there are possibilities of fraud and all of that, right? So you were one of the first government entities that actually used ML to do a lot of analytics, a lot of fraud detection basis the data that you had. Can you share a little bit about that?
Yeah, so just taking a step back, that there were many new things in this scheme. One was that it was cashless and paperless, and end-to-end it was supported by this platform. It is, not was, it is supported by this platform. Second was that it was nationally portable. Even if you're from Bihar and government of Bihar is paying for your expenses, you can, and you're working in Mumbai, you can use services in Mumbai. Government of Bihar is going to be paying that. And so that was built in, and large number of our treatments are being provided by such national portability. Third is this for fraud and abuse. In one of the first meetings, Prime Minister had told me कि देखिए इंदु जी, जो फ्रॉड है ये कैंसर की तरह होता है. अगर आपने इसको पहले ही रोक दिया तब तो रुक जाएगा, एक बार शुरू हुआ तो ये रुकेगा नहीं. तो आपको इस पे विशेष ध्यान देना है. तो based on that, from day one, we had these protocols in our system and lot of algorithms that we had put in, which we were refining through our machine learning. And we would be looking at patterns like one person coming to take services too frequently, or one hospital providing services which is beyond the capacity, or services being provided which are not age appropriate. For example, a person, 30 years old person getting, say, cataract surgery, which is unusual, or which is not gender specific. That kind of service is there's some things which can happen only to women, and that is being provided to men. So things like those. So we would be raising those flags and sending it to states to investigate and not pay unless that investigation has been done.
Got it. So very interesting. And one more thing you mentioned, you talked about the organization that you had put together at the National Health Authority. I had an opportunity to go to NHA a few times, and I can tell you the vibe there is that of a startup, right? While it goes through all the government procedures, it's headed by IAS officers, but there are a lot of private sector folks, a lot of young professionals working there. And there are not too many government entities like that. I remember Aadhaar was one such entity, UIDI, it also in the same building in Connaught Place earlier. Similarly, recently I had gone to RBI Innovation Hub, which is an extension of RBI. That's also a similar feel. But NHA was one such entity, continues to be one. So was it a conscious choice? And then how could you manage that in the government setup?
So, of course, it's a conscious choice. But, it's much easier to do that in a new organization where, like I was saying, we started with 2. So we had the choice of engaging people. And I was told very clearly by one of my senior colleagues that, don't go for government people because you have a choice. Why don't you get people who are younger and maybe find a different route? So, but it is possible only for some time because, in the government. Because after that, you have to give in to the system, and system is going to be putting in people. Also, it has a merit because, you can't run an organization like startup forever. And it happens with startups as well. When startups start, they are lean, very agile, and they are much more flexible. But when they become bigger, they have to put systems in place, and they have to bring in more rules, and flexibility goes down because you want more predictability. So I can tell you that, of course, NHA is like any private sector right now because of many young people. But slowly and slowly, government has been putting people.
It's become government-like.
And it will become government-like in times to come. And I'm not saying that it's bad, but it will have a different character.
Got it. Great. We'll talk about the impact of PM-JY, and we'd love to hear that from you. But before that, what are some of the key challenges you feel the scheme still has? It has had a huge impact, but what are some of the challenges? Recently, there was also a CAG report and got discussed in the parliament as well. And of course, some things get misinterpreted, but from your perspective, since you were in the driver's seat at the time, what do you see as the biggest? You can put the report in.
Gaurav, if you don't mind, let me discuss about the achievement first before going to challenges.
Okay, let's talk about.
Otherwise, it looks like that my scheme has challenges, and of course, every scheme has challenges. And
I'm not. It's not a positive note, but let's start.
I'll come back to positive later. But scheme has been running for less than 5 years, and it has provided more than 5 crore treatments. And currently, it's providing about between 40 to 50,000 treatment every day, and in a cashless and paperless manner. So by any yardstick, it's not a small achievement, and I think we should be thankful to the government and to the. But at the same time, also government has put in 65,000 crores, and our calculations are that although the government has put in 65,000 crores in the scheme, the people who are using them have saved more than 1 lakh crores because the services are being provided at a subsidized rate. Had they gone themselves to seek those services, that will be much more expensive, because then you have this individual negotiation with the provider.
Collective bargaining.
So this is a collective bargaining, strategic purchasing has been done. So it's much cheaper. And again, like I was saying, that lot of services are provided outside the states. Lot of where, and what is also happening because of the scheme is that there are services coming up in smaller tier 2, tier 3 towns, private sector services, because earlier private sector did not have incentive to invest in smaller towns because there was no paying capacity there. Our paying capacity was not as good as in the big towns. Now with Ayushman Bharat, because a lot of people have that paying capacity through Ayushman Bharat, it has become much more viable to have these hospitals in smaller cities as well. And on 6th, I'm doing this talk in Mumbai, where I'm together with some hospital chains which are expanding in smaller areas, and their business model is based on Ayushman Bharat. So Ayushman Bharat is also leading to increase and availability of services at tier 2, tier 3 and tier 4 cities. So that is another thing. So that has been the benefit, and I'm sure if the momentum continues, this scheme is going to be expanding, providing better services to people who have not seen this, both in public and private sector, and the vision will be completed. And I've said this before, that when the health sector history of India is going to be written, we'll have period of before Ayushman Bharat and after Ayushman Bharat. So I think in that sense, early days, 5 years is not a small, is a very small period for judging any scheme. We'll have to come back much later and see what happened, and I hope this momentum continues. But that is not to say that scheme does not have challenges. There are a large number of challenges, and it is to be expected that there will be challenges in implementing a scheme of this complexity. And there are large number of challenges, but I'll focus on 3. First is about the database of the beneficiaries, and it's based on 2011 socioeconomic caste census, and we found that this database is not very strong. The quality is quite poor, and we need to improve it. We need to change that to some other thing, maybe ration card or some other thing. So that's one, and work is being done on this, and hopefully very soon we'll see. And also the work is being done on missing middle, because there are large number of people who be left out, who are too poor right now to buy any private insurance, but too rich not to qualify for this. So that's
the middle, let's say the
middle,
quartile.
the middle.
Yeah.
So there are efforts going on to include those in the schemes. That's number one. Number two is how to encourage private hospitals to be more actively involved in this. Because, private hospitals have many, there are many dimensions to it. Of course, there are some private hospitals who are very keen to be working with Ayushman Bharat. They don't have problem. There's a good anecdote I want to share with you. With actually Prime Minister told me in a meeting. He said कि अगर आपने ये स्कीम बना दी और आप सोचते हैं कि प्राइवेट हॉस्पिटल अपने आप इसमें आ जाएंगे, तो आप थोड़ा सा यू आर मिस्टेकन. क्योंकि मैं आपको एक कहानी बताता हूँ कि गुजरात में एक सेठ था. उसने कहा कि मुझको कुछ परोपकार करना है, मैं रोज़ 50 आदमियों को खाना खिलाऊंगा, सुबह लंच कराऊंगा 50 गरीब लोगों को. तो एक होटल में उन्होंने कहा कि आपके पास इतना, आई होप यू अंडरस्टैंड हिंदी, मोस्ट ऑफ यू. So he said that he went to a hotel, a restaurant. He said, you have a capacity for 50, extra capacity for 50 people, and I will give you lunch money for 50 people for 1 month, and I'll send 50 people, you feed them. And hospital were very happy that I'm getting assured income for 1 month. And next month when he went to pay the money, he said, sir, I don't want to take this, because you send all these beggars and other people, they come and sit here, and when they come and sit here, my regular clients don't want to come and sit here. So he said in hospitals also the same thing will happen, that when large number of clientele is poor, people who are more privileged would not like to go there. So I think that is, my going back to my basic point, that getting private sector involvement is extremely important. And for private sector, one of the key issue is two issues. One, the price, and second is the payment on time. So on pricing, we have to have some trade-off. If the price is too high, the scheme becomes unsustainable. We are going to be running out of funds. Price is too low, it's not viable for hospitals. So we have to find the right price, that middle point, the sweet spot where we can get hospitals to be more actively involved, and that work is still going on, and that has to be refined. Number two, paying them on time, because unless you pay hospitals on time, and many other schemes have not been doing that. Ayushman Bharat, I was very proud of the fact that we were paying within 15 days, and if the payment was being done later, we would be calling them, we could be calling the states and insurance companies to make sure that payment is done. And so I've been away for 2 years, so I don't know now, but that is another thing. But more important thing is that in some places, UP, Bihar, North India, there aren't many private sector hospitals, especially in aspirational districts, in districts where, we have to come in, and government has to provide some incentive to have some public-private partnership in terms of developing more hospitals, so that this scheme can, because we are creating huge demand, and for this demand to we need to have supply. So supply has to, and supply doesn't come overnight. We need to work on that. So that's second thing that we want to do. Third thing is that, you talked about Ayushman Bharat, the PM-ABHIM, but there's another part of Ayushman Bharat, which is health and wellness centers. And health and wellness centers, we have established 150,000 health and wellness centers, and each health and wellness center looks after 5,000 people. So now there has to be a better connect with these health and wellness centers. I say that why? Because, health and wellness centers are screening all the people. They're finding large number of people have cancers. And if they find that person has a cancer or likely to have a cancer, then they should be finding the person the right treatment. So that kind of referral should come from health and wellness center. But more important is that when the person is discharged from Ayushman Bharat PM-ABHIM, goes back to community, follow-up has to be done, because some of them will require treatment for their whole life. You have bypass surgery, and then you have to have medication forever. You have, say, knee replacement, you need physiotherapy after that. So all that follow-up support has to be provided by a health and wellness center. So that kind of linkage between the two strong pillars of Ayushman Bharat have to be maintained. That's another challenge.
That's a good segue also to zoom out a little bit and talk about Ayushman Bharat as a whole and not just PM-ABHIM. So I was speaking to Dr. Rajesh Bhushan, who's been health secretary for most of the last 3 years, and he was explaining the different pillars of it. One is, of course, the first one was PM-ABHIM. Then was health and wellness centers that you touched upon, which are basically these facilities, for 50,000 of them, around 2 crore are planned across the entire country, which are focused on preventive and health. Then there is the health infrastructure mission, which is a key part of Ayushman Bharat. So that's the third pillar. And the fourth is the ABDM, Ayushman Bharat Digital Mission, which is to create a longitudinal health record for everyone in the country. If you have to look at Ayushman Bharat as a whole and slightly crystal gaze into the future, let's say 10 years from now, what's your own? Are you hopeful about the healthcare situation and public health in the country? If yes, what are some of the tailwinds that we have that will help, and what are some of the challenges or headwinds that are there? So a little bit as a public health professional, what you do look into the future?
I'm glad that you mentioned about all 4 elements, but I would like to pick up on Ayushman Bharat Digital Mission. Now it's called ABDM, and it was launched by me, of course, launched by the Prime Minister, but I was there for starting the pilot. And this is a mission which is providing the digital infrastructure for health system in the country. And if it does well, it will do the same thing for the health sector that UPI has done for the financial sector, because it will digitize all the records and exchanging of record based on consent and portability of record. Right now, your image of people going to the hospital for any tertiary care, they would have a huge file under their arm, which have tattered pages and some missing reports, and some hospitals not sharing their reports, and they are in a form that can't be read sometimes. So that is all going to change with the ABDM, and it's making a good progress. And it was given to NHA, where I was working, which actually implements Ayushman Bharat PM-ABHIM, because under PM-ABHIM, we had provided that kind of a framework already. Because in digitizing health sector, you need to have each person having a unique ID. You have to have all the hospitals having a unique ID. You have to have all the doctors and health professionals have a unique ID, and you need to digitize all the health records. And we were doing all of that because under our platform, 40% people that we are covering, they were being given one ID. All the hospitals which are working with Ayushman Bharat, which is more than 26,000, have a health ID, and all the treatment which is being given under Ayushman Bharat is digitized.
Yeah.
So we were already preparing that framework, and that's why
that became the basis for ABDM.
we need to upscale it for the whole country, and so that work is being done. So 10 years from now, if this is successful, we would have bypassed all the problems that developed countries have seen, that all their digital health is all in silos and controlled by different hospital chains, and they don't want to share information. It's very difficult to take your record from one hospital to other hospital. That will not happen, and I think we'll have a much more smoother, and that is the benefit of doing it later, because this is more
Learn from mistakes of others,
so
and now
learn from mistakes, and also we don't have legacy systems and that we need to fight, right? So that will happen. And with the large investment coming under Ayushman Bharat infrastructure project,
health infrastructure mission,
mission BHIM, so we will have a very strong network of hospitals at district level and strong public health infrastructure, and with both health and wellness centers, very strong primary health care and secondary and tertiary care through Ayushman. So it's a huge step towards universal health coverage, and I am very positive, optimistic and gung-ho about the fact that in 10 years' time, probably our health indicators will be top there among the best. Right now, if you look at it, all our health indicators, bar none, are the lowest among all G20 countries. And I have a feeling that in 10 years' time, that situation will change.
Great. On that positive note, a couple of quick questions on your own journey, and then I'll open it to the audience for a couple of questions. I talked about your journey, that you left the civil services, you took voluntary retirement, 9 years into it. Why did you do that? I did touch upon it then, but why did you do that? I know why you came back, but why did you take that call? Not many people do that.
Okay, so just one correction, that I didn't leave after 9 years.
Okay.
After 9 years, I had gone for my PhD. And I used to be collector, and in some states you call them district magistrate or DC. So I was collector of Dausa in Rajasthan, and from there I went to do my PhD, and I was keen to do my PhD, and I'll come back to it later. And I didn't have money, and I didn't get any funding, but I had this feeling that I go there, I will get funding. So I was just going for first 1 year to do masters, and if I'm successful. But I didn't have money even for 1 year. So I sold my car, which was given to me by my father. Father had told me that if you come to IAS, I'll give you a car, and he gave me a car. And I didn't tell him, because he would have really been mad that I sold the car he gave me. And I had some money, and I went to Jaipur and got the money transferred to dollars. It was very difficult in those days to do that. I could do that. And my PA was saying that, sir, I don't think this is a good thing. You should life savings. What are you going to gain by doing this PhD? And he was thinking that I'm out of my mind. Of course, as a DC or a collector, you have a huge house. I went to a dorm there, which is a one maybe bedroom, like small room like this. Then he would also call me once in a while, "Ki, sir, how are you doing?" I said, please don't call me so much. I have to do laundry. I have to do, I have to do dishes. So he would think that I'm just joking, but no. So I did my PhD, and then I was working with the World Bank, and government had given me permission for doing that in Washington DC. And then I went to Asian Development Bank, gave me a job, and I thought maybe let me try this. And at that time, when I went to ADB in Manila, and I started working, I liked the job. And at that time, Government of India didn't give me permission to work with ADB. And my family was very keen that, we stay there. My children loved the school. And so because of that, I left. I didn't leave with, I'm from UP. And in UP, when you become an IS officer, and I was in UP cadre to begin with, actually, I shifted to Rajasthan later. And then people think, you have found the ultimate, at least among the middle class families. And so leaving an IAS job is not an easy thing. But I thought it was, instead of a civil servant in India, I was an international civil servant, and because of that I left. But I always wanted to come back, and that's why when this call came from PMO, it was a no-brainer, irrespective of the fact that I took 95% salary cut. I wanted to come back and do this work.
Yeah. And I think your entire family is into public health service. Your wife, also ex-civil servant, she studied public health. Your daughters are into medical, this thing. So, you talk about health?
Actually, we don't talk about health because, all of us are in different field in a way. My two daughters are doctors, and they are based in the US. And one of them actually is a doctor in a hospital called Cedars-Sinai, which is on Sunset Boulevard in Los Angeles, is heart of Hollywood. And she has a lot of famous patients, but she never tells me who comes. She says, Papa, you have a big mouth. You'll just go and tell people, you'll just brag that I'm seeing so and so, and I'll be in trouble because it's not allowed by, say, data privacy, personal privacy is taken much more seriously there. So she never talks to me about what she's doing during the daytime. My other daughter, I'm very proud of her. She became acting Surgeon General of California State at the age of 35. And now she's doing her own thing. And she works on, she's a pediatrician, but she works on mental health issues. My wife works with WHO. She is still with WHO regional office. And she works on gender issues and social issues related to health. And of course, she's, but we've decided not to talk about health at home because otherwise, it will become very
too much of health. What do you do outside of work?
Well, I play golf, and the only thing I was not very happy about today was that because I had to leave my golf. But yes, otherwise I really wanted to come. I play bridge. I watch movies. I travel a lot.
What kind of movies?
I've been now I have to do more and more OTT. And I travel. I love traveling. I was in Mexico about a month ago. So Mexico was my number 80 country. So I've been to 80 countries. My goal is to go to 100 countries.
That's a lot more than what consultants do also, right? Great. On that note, let's take a couple of audience questions. If you can raise your hand, we'll take the questions together and then he can answer. Yes, one we'll take from there. One, that lady in the pink.
Firstly,
let's take.
Firstly, Indu Bhushan sir, over here. I'm Dr. Harpal Singh Malhotra. I was part of British government, and I was in touch with Dr. Dinesh Arora, Love Agarwal, Dr. Manohar Gnani, all of them. And your email, I got the quickest response ever from. And I think you recently then joined Ayushman Bharat. My question now to you is, it has two parts. First and foremost is it's not easy to keep all the stakeholders happy, right? And you're doing such a big task. The first, most important was I think keeping hospital industry, the owners happy. So how that pricing you mentioned, how if you can just deep dive and let us know about that part. Secondly, fraudulent, you mentioned, I think I was also part of TPA, and then RSBY, I visited, I'm narrating one small incident and the question lies there.
Let's come to the question.
Okay. That's about how you handle that fraudulent part as well. Thank you so much.
Yeah, let's take the second question also.
Thank you so much for the session. My question is that to really bring impact, what is the difference between government and private interventions, and which of the two can be more transformative, faster, and more impactful? Also, what is the core difference in which the two of the kind of interventions, public policies or private entrepreneurial setups or private interventions? What is the core difference between how the two function?
Yeah, let's answer these two. If you can take these two, and then we'll take maybe two more. Yeah.
All right. So that is a major thing that any leader has to deal with. Any decision that you will take, will of course benefit a lot of people, but there will be people who will not be, who will be adversely affected. And so you can never keep everyone happy. I used to have a boss, and he would say that, if all your stakeholders are unhappy for something from you, then probably you're doing a good job. But again, there are some key stakeholders like hospitals. Now you have to work with them in a way that they may not be happy with you, but at the same time they're not unhappy, or they're not seeing that you are not fair. And that can be done only through a very objective analysis and discussion and based on data. So even yesterday I was in some social gathering, and the head of one of the major chains, we had a long discussion on how the rates are still unviable. And so my sense has been that, give us more data and justify that this is your cost structure, because while hospitals would ask for better rates, but they would not share with us the data about their inputs and structure. So we did our own studies. Since you worked there, you would have known that we had a big team working on that, including DGHS. And our own calculation was that this is the real data. And, I had also consulted with some doctors. And once IMA president came to me with large delegation, and he was saying that, you have put 9,000 rupees for cesarean section, इसमें तो हो ही नहीं सकता आप. So I, in front of him on my phone with the speaker on, I called a doctor, gynecologist, and I asked her that for C-section, how much is your cost? And she said कि करीब 4,000 में हो जाता है. तो मैंने कहा ये करिए 4,000, हमने आपको 9,000 दिया है. तो they started bashing her कि नहीं, उसने वो she must be doing something, cutting some corners, not reusing some of the inputs like tubes and all. So and maybe simple C-section is 4,000, like inputs. I'm not talking about the so there's a lot of opacity about the input costs, including drugs. So I think unless we can get some handle on that, so if you have this fair discussion in terms of give us more data and we'll be happy to respond. And when they give you data, in many cases actually we changed it, we increased the rates. Also, we also wanted to be sure that, while we were giving lump sum for a procedure, later on we changed it, divided into two, that we will be giving separately for any devices or inputs you use. For example, the kind of stent you put or kind of lens you put for cataract, we'll pay you separately so that you don't provide poor quality devices. And so for devices, separate payment, and for procedures, separate payment, that helped. So, but keeping them always happy is difficult. And I would say that large proportion of hospitals were okay. The private sector would always like more and more, but they were not unhappy. Some part of hospital chains were still not happy, and so it was always a source of some friction with the industry. And in any meeting I would go, the major discussion was on prices. So
you will also answer the second question, Dr. Bhushan.
Yeah, second question, government has some strong points, and private sector and NGOs have very strong points. And government can do things on scale. They can do it for long term. They can make it part of the system. They can also provide large resources. At the same time, private sector and NGOs, I found, are more flexible. They can be more innovative. They can provide things. They can develop very innovative models. So I think marrying both, where the ideas proof of concept and innovations can come from private sector and NGOs, and that can be taken up for large scale application in the government. And also private sector can or NGOs can play a role in terms of monitoring and giving feedback on what is happening in government schemes, because which is missing, because there's in the government probably one of the weakest link has been that our feedback loop is very weak, that what is happening in the at the real last mile, we rarely have this feedback whether things are working well or not. So this feedback can also be very important so a partnership between public and private, especially with NGOs and private sector, is key here.
It's not an or, it's an and both have a different role to play. We're run out of time, so we'll not be able to take more audience questions. We'll have to take it offline. But last thought from you, Dr. Indu Bhushan, we have the ISB students sitting here. There's a much larger young professional or students out there who want to somewhere contribute to nation building in whatever shape and form. But a lot of things come in the way, right? Your opportunity cost, the placement on campus versus doing something like this, career trajectories are not that linear and so on. So what's your message to the youth who wants to do something, but sometimes tend to hold back?
Okay, so I have two messages, Gaurav, and both these messages come from my own experience and may not be relevant for all of you, but probably they will be. First message is that, and which actually I didn't see this future proofing thing, because like I was saying, when I started my job, I thought it's a job for life, and I will retire as Secretary to Government of India, or hopefully I'll become Cabinet Secretary. That was my dream at that time. And many of my batchmates from IIT and later on went to IIM, and they picked up jobs. But I can tell you that many of those jobs are not there anymore. At that time, Kodak and Xerox were very sought after companies. They were it was a dream for people to get them. Now those companies don't exist. The way we do business has changed a lot. At those days, of course, we didn't have the smartphones. We didn't even have computers. It was a luxury to have a desktop computer which was not linked to any internet. But things have changed in a big way. So this constantly learning, the learning has to be a lifelong thing. You can't say that after you've done this degree from ISB, you are set for your life. I think I can tell you that in your life, on an average, you'll be changing 7 or 8 jobs, and in some cases even more. And the job that you'll go to probably will not exist after some time, after a decade or so. So unless you keep learning and upgrading your skills and revising, and I am so glad that I went to the US. I learned a lot. Actually, I thought I was learning almost every day, if not every week, new skills, data analysis and many other things. It was much difficult at those times because now I think information is available on your fingertips, literally. And in those days, you had to go outside and get that information because there was not much connectivity. So the learning has to be there lifelong, because you are dealing with a lot of uncertainty, as Mr. Ram was saying, that if you have to deal with uncertainty, probably you have to have a very versatile background, number one. Number two is that, all of you are very privileged. The reason that you come here and you can be part of such a great institution and such a beautiful campus, you are really privileged people. But 99% of the population is not as privileged, or I would say 99, but large proportion of our country is not as privileged. And so having come here, probably you need to also see that how you share your privilege and ensure that you give it back and be the kind of passion I see here in this room. And you need to also bring some compassion with that and see how you can make a girl child happy or smile, which is who is on the street. So while I would, of course, not say that you should not be going into a lucrative and career, whether it's business or corporate sector, but at some point in time, you should think of giving it back to society and see if you can do something for society, even at the cost of earning less. I think that's, I'm saying it very sincerely. And unless people like you who are so bright and have a great future, think about it and do that, probably no one else would.
Thank you, Dr. Indu Bhushan.
Thank you.
Pleasure to host you on stage.
Thank you.
Thank you.